WHO guidelines recommend using a single quality assured serological in vitro diagnostic test, either a laboratory based immunoassay, enzyme immunoassay, or chemiluminescence immunoassay, or rapid diagnostic test RDT to detect hepatitis B surface antigen that meets minimum performance standards. Using HBV DNA nucleic acid testing NAT following a reactive hepatitis B surface antigen serological test result is recommended to help further guide who to treat and to monitor for treatment response. The use of capillary whole blood dried blood spot specimens for both serological and NAT technologies for HBV infection may be considered for testing in certain settings. Hepatitis B surface antigen positive people need to be routinely assessed to guide management and indicate the need for treatment. This generally includes assessment of additional serological markers of HBV infection, hepatitis B e antigen, measuring aminotransferase levels to help determine liver inflammation, quantifying HBV DNA levels, and determining the stage of liver fibrosis by non-invasive tests such as AST to platelet ratio index APRI, transient elastography, fibroscan, or fibrotest. A full assessment includes clinical evaluation for features of cirrhosis and evidence of decompensation and measurement of serum bilirubin, albumin, ALT, AST, alkaline phosphatase, and full prothrombin time, as well as blood count, including platelet count. Other routine investigations include ultrasonography and alpha-fetoprotein AFP measurement for periodic surveillance for HCC and endoscopy for varices among people with cirrhosis. Detection of viral DNA is the optimal method of quantifying hepatitis B viremia and for monitoring HBV replication before, during, or after antiviral therapy. Serum HBV DNA concentrations quantified by PCR correlate with disease progression and separate hepatitis B e antigen negative infection from hepatitis B e antigen negative disease. WHO standards are available for expressing HBV DNA concentrations. Serum HBV DNA levels should be expressed in IU by ml to ensure comparability. Aminotransferase levels may fluctuate with time, and single measurements of ALT and AST do not categorically indicate disease stage. The ALT concentrations are usually higher than those of AST, but with disease progression to cirrhosis, the AST to ALT ratio may be reversed. Tests of liver synthetic function and or portal hypertension include serum albumin, bilirubin, platelet count, and prothrombin time. Liver biopsy had been used in the past to ascertain the degree of necroinflammation and fibrosis and to help to guide the decision to treat. There are several established methods of scoring histology and measuring activity separately from stage. For fibrosis, the activity of HBV can vary over time, but the degree of hepatic fibrosis determines the prognosis. Non-invasive methods for assessing the stage of liver disease have largely supplanted liver biopsy and have been validated among adults with chronic hepatitis B. Blood and serum markers for fibrosis, including APRI and FIB4, as well as commercial markers such as fibrotest, can be estimated or transient elastography fibroscan performed. This table presents the summary for hepatitis B laboratory results. The ingestion of high levels of biotin can significantly interfere with certain commonly used biotin-related immunoassays and cause false positive or false negative laboratory test results. People who receive hepatitis B vaccine might be transiently positive for hepatitis B surface antigen, with reports of transient positivity 18 days post-vaccination. Retesting of patients who are positive for hepatitis B surface antigen shortly after hepatitis B vaccination at a later time is needed to determine the true HBV infection status. The total anti-HBV positive is isolated could result from loss of anti-HBs after past resolved infection, HBV DNA is negative, false positive total anti-HBC, an example susceptible, HBV DNA is negative. To resolve the ambiguity of false positive total anti-HBC results, test a follow-up sample 4 to 8 weeks later. If found positive, interpret as a resolved infection. If negative, interpret as false positive. 3. Passive maternal transfer of total anti-HBC to infant born to a hepatitis B surface antigen positive gestational parent for up to 24 months. HBV DNA is negative. 4. Occult HBV infection. HBV DNA is positive, typically at low levels. Anti-HBs might or might not be positive. 5. Hepatitis B surface antigen mutant infection. HBV DNA is positive, typically at high levels. Anti-HBs might or might not be positive. Hepatitis B surface antigen mutants will not be detectable if testing was performed using an older assay that cannot detect hepatitis B surface antigen mutants. Hepatitis B surface antigen mutant strains can be detected by some assays that first became available in the United States in 2015, including Abbott Architect instrument. The following laboratory markers are recommended for reporting to public health, as they can aid in case ascertainment, case classification, and monitoring care for hepatitis B in the USA. Positive hepatitis B surface antigen, positive or detectable HBV DNA, including quantitative, qualitative, and genotype testing. Positive hepatitis B E antigen, positive anti-HBC IgM. If any of the above positive results are reported, also report the following: pregnancy status, concurrent ALT and total bilirubin result, or other hepatitis serological results, example hepatitis A, hepatitis C, hepatitis D, and or hepatitis E, total anti-HBC results, negative hepatitis B surface antigen, negative or undetectable hepatitis B virus DNA results, total anti-HBC is detectable on average approximately 5 weeks post-HBV exposure, remains detectable indefinitely following exposure, and indicates past or current infection. In the presence of total anti-HBC, a positive hepatitis B surface antigen, hepatitis B E antigen, or anti-HBC IgM result is more reliable indication of current or recent infection, while negative total anti-HBC results can be used to determine that a person is not a case. What are the phases of chronic hepatitis B? Chronic hepatitis B virus patients experience episodes with fluctuating serum levels of viral DNA and alanine transaminase ALT liver enzyme levels. These patients are classified into clinical phases: hepatitis B E antigen positive chronic infection, hepatitis B E antigen positive chronic hepatitis, hepatitis B E antigen negative chronic infection, hepatitis B E antigen negative chronic hepatitis, and hepatitis B surface antigen loss phase. 1. Hepatitis B E antigen positive chronic infection phase is characterized by high levels of hepatitis B virus replication, typically above 107 IU per ml, with normal or near normal serum aminotransferase ALT levels. Minimal necroinflammatory change on liver biopsy, no or slow progression to fibrosis, and low spontaneous hepatitis B antigen loss. This phase of the disease is typically present among children, adolescents, and young adults infected at birth or in early childhood. This phase has been previously delineated as the immune-tolerant phase. 2. Hepatitis B antigen-positive disease may be followed in young adulthood by a stage characterized by the continued presence of hepatitis B antigen and relatively high serum HBV DNA concentrations, typically between 105 and 107 IU per ml, but raised serum aminotransferases indicating active inflammatory disease. Cytolytic T-cell responses directed at infected hepatocytes leads to elevated ALT and reduced HBV DNA levels. The intensity of the periodic exacerbations varies. 3. Hepatitis B antigen negative infection. Some people, about 10 to 15% per year, spontaneously seroconvert from hepatitis B antigen to anti-HBe and may show a marked decline in HBV DNA and serum ALT concentrations. These individuals, previously referred to as inactive carriers and also as the non-replicative or inactive immune control phase, typically show near normal 7 serum aminotransferases and HBV DNA concentrations of below 2000 IU per ml. However, despite low concentrations of HBV DNA, hepatitis B surface antigen concentrations can remain high, above 1000 IU per ml. A proportion show little or no necroinflammation or fibrosis depending on the timing of seroconversion from hepatitis B antigen to anti-HBe. 4. Hepatitis B antigen negative disease. Conversely, hepatitis B antigen seroconversion can occur a change to hepatitis B and antigen negative disease with mutations in the precore or basal core promoter downregulating hepatitis B antigen despite continued HBV replication. Hepatitis B antigen negative disease is characterized by fluctuation in serum ALT. HBV DNA concentrations are lower than found among hepatitis B antigen positive people and typically between 103 and 105 IU per ml, but higher than in hepatitis B antigen negative infection. Hepatitis B surface antigen concentrations can remain high, above 1000 IU per ml. Hepatitis B antigen negative disease has a variable course with abnormal fluctuating levels of serum ALT and HBV DNA, necroinflammatory changes, and more rapid progression to cirrhosis, annual rate of 8 to 20%. Recurrent exacerbations and bridging fibrosis with severe necroinflammatory change characterizes people who are more likely to progress. Distinguishing between anti-HBe positive infection and anti-HBe positive disease is difficult without longitudinal follow-up of serum HBV DNA and serum aminotransferase concentrations. 5. Occult HBV infection. It is defined as persistence of HBV DNA in the liver or serum among people for whom hepatitis B surface antigen is not detectable in the blood. People who have cleared hepatitis B surface antigen but are anti-HBC positive may reactivate if given potent immunosuppressive drugs. Subjects with occult infection are a potential source of new infections in blood transfusion services when hepatitis B surface antigen is used as the sole marker of infection in donor populations. HBV reactivation may occur spontaneously or may be triggered by cancer, chemotherapy, and other immunosuppressive therapy, and may lead to fatal acute on chronic hepatitis, and preemptive nucleotide analog therapy is therefore used.